Hello, and thanks for joining us for today's webinar from the Institute for Research on Poverty at the University of Wisconsin-Madison. I'm Dave Chancellor, and I'm going to be your host. We're going to be talking about reducing adverse birth outcomes in the next hour, and I'm very happy to welcome our presenter, Dr. Deborah Ehrenthal. We're really fortunate to have Dr. Ehrenthal talking with us today. So she is the Life Course Initiative for Healthy Families Endowed Chair here at the University of Wisconsin, the Director of the Division of Population and Reproductive Health and Obstetrics and Gynecology here at the School of Medicine and Public Health. And I should also mention that she's been one of the leaders in developing a new interdisciplinary initiative here at the UW that was just announced a couple of weeks ago, focused on reproductive equity. So that's kind of a big deal and directly related to what we're talking about today. So congratulations on that, Dr. Ehrenthal, and yeah, just more generally, thanks again for being here. I also want to thank the Office of the Assistant Secretary for Planning and Evaluation at the Department of Health and Human Services for their support of this webinar series. That said, any opinions or positions expressed in today's webinar aren't necessarily those of ASPE or IRP. So here's how our webinar is going to work today. In a moment, I will turn it over to Dr. Ehrenthal, and she'll have the floor. And we'll save the final 10 or 15 minutes today for your questions, but you should feel free to type those in at the bottom of your screen throughout the webinar today. We'll also be recording the webinar, and I expect to send out a link tomorrow or Friday to all of you that requested that during registration. And we'll also have that posted on the IRP website. So with that, Dr. Ehrenthal, again, welcome. We're going to turn it over to you now.
Great. Well, thank you so much, and thanks for that wonderful introduction. I am thrilled to be able to talk with everybody about this really important public health issue. So I'm just going to start by describing the outline of today's presentation. I'm going to start by just talking about birth outcomes for the U.S., talking about infant and mother's health, and comparing them to international outcomes where we think we fare pretty poorly. Then I'll talk a little bit about current trends and the characteristics of women having kids in the U.S., which we know is pretty dynamic at this point. And then finally, I'll talk about how we, from a population health perspective, think about what contributes to health and how we can use that to identify strategies to improve maternal and child health. So we'll start by looking at birth outcomes. I always find it helpful to remember that we've seen an extraordinary improvement in infant health during the last century. And as we see from this figure of national data, the infant mortality rate since 1940 has plummeted. That's been a decrease in both neonatal mortality, which is death within the first month of life, as well as postneonatal mortality, which is a death that occurs before the infant turns 1 year of age. And that's a really tremendous result of both public health and healthcare strategies that have impacted the health of infants across the country. But we are now in the U.S. an outlier among other developed countries. So even though we've seen this tremendous improvement, if we compare our outcomes to those of other OECD countries, as we see here in this figure, we fare poorly. Infant mortality rates or death of infants under 1 year of age are much lower in other countries across the world, other similarly developed countries. And much analysis has gone into really showing that this is not due to differences in definitions of mortality. There's truly a survival disadvantage for folks living in the U.S. Now, we have seen, as I showed since 1940, tremendous improvement. And even though there's continued efforts to decrease infant mortality, the improvements have really slowed. And what's particularly apparent is we continue to see tremendous disparities for infants born to African American moms. And here we see, even though this nice, very slow trend continues, we're not closing the gap in infant mortality in the U.S. Here we see that non-Hispanic black moms, babies, die at 2 to 3 times the rate of babies born to other moms. And in fact, kids born to Native American and Alaska Native moms also have higher rates than all others. So while we continue to see slow improvement, we really haven't closed the gap in disparities. It's interesting when we look across the country to see that infant mortality rates vary by state. This is a map of the most current data that's put out from the National Center for Health Statistics. And the numbers are tiny and can be hard to read, but what we see here is that the overall infant mortality rate in the U.S. is about 6 per 1,000 live births, 5.89. But there's a wide range. The lowest infant mortality rates are in the state of Massachusetts at 4.28, and the highest are in the state of Mississippi at 9.08. So wide range, suggesting that there's a lot of factors that matter and are driving these rates and that differ by region. Here's a map showing infant mortality rates for infants of white moms, and again we see a wide variation. The lowest rates are in D.C. currently at 2.5, and the highest rates in Arkansas at 7. And then here we look at a map of infants to black moms, and we see this much higher rate of infant mortality at 11 overall, and again, a very high range, with the lowest in Massachusetts again, and the highest in my state, in our state of Wisconsin, at 4.28. So this disparity has been persistent and hasn't been impacted by many of the strategies that we've used. This slide just depicts the leading causes of death among babies who die, and it's important to think about what the pathways are to infant mortality. The most common diagnosis identified in birth records are birth defects, congenital anomalies, as a leading cause of death. But right on its tail are preterm birth and low birth weight. Sudden infant death syndrome, now called sudden unexplained infant death syndrome, is the third most common cause. And then we see maternal complications and unintentional injuries. What this slide also does show us is that we are seeing some slow improvements in each of these diagnoses, but a rise in unintentional injuries contributing to infant mortality. So because preterm birth is such a critical driver of adverse birth outcomes, I'm going to talk about it in a little bit more detail. Preterm birth, again, shows large racial disparities, and here we see some trends over time, primarily to highlight the high rates of prematurity among African Americans. And the causes of prematurity are very complex. Let me move along. I'm going to move here. The preterm birth is really multifactorial. It's a critical driver of infant mortality and the major driver of racial disparities in infant mortality. From a clinical perspective, we think about prematurity as coming through two primary pathways. One related to spontaneous preterm birth, women who go into preterm labor or have a premature rupture of membranes that initiates labor. And that's one of the most important conundrums for healthcare providers, is how to stop labor once it's started. There really have been very few, or essentially no effective strategies to stop it once it's begun. But there's much research that's now going into identifying strategies to prevent that spontaneous prematurity, especially among women who've had a prior preterm birth because they're at such elevated risk. Strategies that people are using today include the use of progesterone supplementation. I'm not sure if folks are familiar with Makena or 17P as a supplement that can prevent recurrent prematurity among women with a prior preterm birth. And also the use of cerclage, which has come and gone in favor, but is again being used to stitch the cervix closed and try to prevent recurrence. But there are multiple mechanisms that lead to prematurity, including stress. And stress is not a factor that the healthcare system can really address and is the ever-present factor driving much of spontaneous preterm birth. Another piece of preterm birth is medically initiated early delivery related to maternal health. There's a couple of really interesting aspects of this. One is that there was a growing increasing use of medically initiated birth, so either a labor that's induced medically or a cesarean delivery that is scheduled prior to 39 weeks, so a little bit on the early side, that became almost standard across country. And large population-based epidemiologic studies identified the adverse effects of this. Much work has gone into showing that women's outcomes and infant outcomes are better for infants who are delivered at 39 weeks than they are at 37 weeks. And so that medically initiated early delivery was identified as a public health problem and as a driver of adverse outcomes for the infants and mothers, and some quality improvement strategies, which I'll talk about later, have been mounted to eliminate that. The other piece of medically initiated early delivery is related to outcomes for women with pregnancy complications. A great example of that is a woman with a hypertensive disorder. Hypertensive disorders are the leading cause of morbidity and mortality for mothers and infants during pregnancy. They occur somewhere between 5 and 10% of all pregnancies, and they can lead both to poor fetal growth during development, so a failure to gain weight and a failure to achieve optimal growth in utero, and they also can lead to very serious illness for mom. So over time, there's been a recognition that for some moms, the pregnancy, ending the pregnancy earlier leads to better outcomes for both the mom and kid. So some of the medically initiated early delivery is due to maternal health problems and likely leads to better outcomes overall. So broadly, preterm birth is a really critical driver of infant mortality and other adverse outcomes. There are no effective medical strategies to stop labor once it's begun, but there are some strategies that can be used for women with a prior preterm birth that are effective. I'm going to go back here. So after a very long period of slow decline in prematurity, unfortunately, we are seeing rising rates again. These data come from the National Center for Health Statistics, and they show here that overall, across all ages in just 3 years, we're seeing increasing rates of preterm birth. And we're also seeing increasing rates of preterm birth by every age group. So broadly, which is very concerning and, as much as I can tell, pretty unexplained. So while we often focus on infant outcomes when we think about maternal and child health, and we typically focus on birth weight and gestational age at birth and mortality, it's critical that we shine the light on how moms are doing. And an important outcome that's been measured over time but has had measurement problems is maternal mortality. Recently, the CDC has mounted a very well-coordinated national effort to do a better job of measuring maternal mortality. And here we have data from 2010 that shows, again, just like with infant mortality rates, the U.S. fares poorly. Here, among this group of countries, we rank 47th. So our maternal mortality rates are similar to those in Turkey, or worse than Turkey, Hungary, Iran, nothing like what we see in other well-developed countries. So what's going on here? Maternal mortality rate is high, as I showed you, and it's been rising. And these data are becoming more and more accurate in their identification of maternal deaths. Maternal deaths or pregnancy-related mortality is deaths within a year of delivery that are related to pregnancy. Here again, we see a large racial disparity. The ratio for whites is 12.7 per 100,000 live births, and for African American moms, it's 43. Extraordinary disparity in maternal mortality. So what's driving that? These are data from the U.S. From a few years ago that look at pregnancy-related deaths and the cause of those deaths. And what we see among those deaths is, instead of what was more typically deaths related to hemorrhage, postpartum hemorrhage, or sepsis, we're seeing cardiovascular disease dominate. So we're seeing 15% of all related deaths are related to cardiovascular disease, 14% other medical diseases. We're seeing high rates of cardiomyopathy, pulmonary embolism, hypertensive disorders of pregnancy, and stroke. So instead of seeing the typical pregnancy-related mortality, we're seeing the results of cardiovascular risk and cardiovascular disease among women in the U.S. Because maternal mortality is so uncommon, another important way for us to be understanding what's driving these outcomes is not just to look at mortality, but to look at severe morbidity. So women who might have a near miss or a significant complication that almost led to death, but didn't. And these are severe maternal morbidities. And here we see data that's collected from hospital discharge data that shows us that over time, over the past decade, we're seeing tremendous increase in the number of women who are having severe maternal morbidities. And here in this figure, you can see that it's dominated by maternal morbidities related to blood transfusion or postpartum hemorrhage. So a really concerning trajectory here in these data. So to summarize the health challenges, after a century of improvements and longer in maternal and child health outcomes, we're seeing very concerning current trends. We continue to see racial disparities in maternal and infant health. They are large and they are persistent. We see high rates of preterm birth and infant mortality and rising rates of maternal morbidity and mortality that are quite alarming. I want to talk a little bit about interesting trends in who's having kids in the U.S. Maybe a part of the story, but it's certainly important for us to think about as we consider strategies to improve outcomes. Well, some of this is, I'm sure, well known to everybody. We read about it in the newspaper, and we hear about it on the radio. The age of childbearing has changed in the U.S. These data are pretty recent. They're since the recession, so from 2007 to current. And what this shows is that we're seeing two concurrent phenomena. One is we're seeing a large decrease in the number of teens having kids. So the teen pregnancy rate has fallen quite dramatically in the past decade. And on the other side, we're also seeing rising rates of births to older women. So women are delaying childbearing, and they're continuing childbearing certainly into their 40s. So two really dynamic changes. The other dynamic change that we're seeing is a change in marital status. So increasingly in the U.S., mothers are unmarried. And if we look at the green line here, we look at the percent of births to women who are not married, and we see it's climbing now. These are from 2010. I know the numbers are higher now, I guess 2013. 40% of women in the U.S. having kids are unmarried. The other data that is important for us to think about and is sometimes hard to get a handle on, and that is understanding other parts of the socioeconomic status of women having kids. This figure is from the Kaiser Family Foundation, and they've come up with estimates of the percent of births financed by Medicaid at the state level. Their estimates show that nearly half of U.S. births are Medicaid insured in 2016. And this map again, shows us the huge variation that we see across the country in Medicaid-covered births. Similarly, part and parcel, about 40% of mothers in the U.S. report receiving WIC during the prenatal period. Again, large differences across the state, but both of these together speak to the socioeconomic challenges of women bearing children. This is data that we've put together from the state of Wisconsin by bringing together data from vital statistics and data from a postpartum survey that the CDC launches in most states, and is certainly here in Wisconsin, called PRAMS, the Pregnancy Risk Assessment and Monitoring System. And I show this to you because it's very tough to really get a good description of the socioeconomic status of mothers giving birth at a national level. So here's some data from Wisconsin. These are data from 2012 and 2013. What we see here in Wisconsin is 88% of moms who had a baby had 12 or more years of school, so they were high school graduates. 74% were 25 and older, and 46% were living at least 200% or higher above the federal poverty level. What we see to the right is we see a nice lollipop figure, which looks at characteristics by race and ethnicity, because it's so important for us to try to understand what's driving our disparities. And here what we see in the red, we see the percentages for whites, and in the pink we see percent for black, and in gray for Hispanic. And what I want to call your attention to just primarily here is the percent of women who are living over the 200% federal poverty level. The vast majority of African American and Hispanic moms in Wisconsin having babies are below 200% of the federal poverty level, whereas it's much less common for whites. So we really see large differences in socioeconomic measures. The other thing that's happening among women in the U.S. is we're seeing changes in baseline health, and this is another national trend, and we see the same trend among moms. Women having babies are more obese. These are data from the U.S. Looking at body mass index categories, and what we see here is that more and more women are not of a normal weight when they enter pregnancy. So we're seeing much higher rates of overweight and obesity among women having kids. And the reason that matters is because obesity is related, is linked to stillbirth. Women who are obese are more likely to have a cesarean delivery because of labor dystocia and other reasons, and therefore more likely to lead to maternal morbidities down the line. We also know that tied to obesity is a higher rate of high blood pressure and diabetes, both of which have profound effects on pregnancy outcomes. So these trends in underlying health are really important as we think about what's driving these worsening outcomes for women and kids. So to summarize these population trends, U.S. mothers are increasingly older and less likely to be married. A large percent of women receive WIC and are insured by Medicaid during pregnancy, indicating poor financial resources. And medical risk factors have become more common, including overweight, obesity, and with it, hypertension and diabetes. And taken together, these social factors, these medical factors, place women at greater risk for adverse birth outcomes, including infant outcomes as well as maternal outcomes. So how do we think about what contributes to health? So what I'm showing here is the county health rankings model that was developed right here at UW by Pat Remington, David Kindig, and others. And it's a model that's really useful in helping us think broadly what's driving health. And I'm going to talk through this a little bit. So when we think about health, we think about length of life, and we think about quality of life. So not just living a long life, but living a healthy life and a productive life. These outcomes are consequences of health factors, some of which are driven by policies and programs. What we see here is an estimate of how much each of these different buckets seem to drive health outcomes. We usually think about health behaviors when we look at the health of the community, when we look at an individual. We ask them, do you use tobacco? How healthy is your diet? Are you exercising? What about alcohol and substance use? These are factors that we typically think about as the factors that drive health outcomes. And then we think, well, what about clinical care? Clinical care is important. There's screening, there's prevention, and then there's access to care when somebody's sick. And we often don't think about the social and economic factors and physical environmental factors that are driving health. And if you broadly look across health and you attribute the different contributors, what we see here is that while health behaviors are important, they're really only about 30% of the pie. And while clinical care is important, and we typically think first of medical care as a driver of health, it's probably only contributing about 20%. But what's filling out the other half of the pie are social and economic factors and the physical environment. So in that context, we can now turn our thoughts to the framework for public health action that was developed by Tom Frieden, who was the director of the CDC and before that of the New York City Health Department. And it's a really important framework for us to use in thinking, in taking what we understand about the drivers of health and using it to think about strategies and interventions that might matter. This is a nice image developed by the Tarrant County Public Health website that I pulled in, and that's supported by CDC. And it goes through a really nice progression through the pyramid. So at the top of the pyramid, what we see is counseling and education. And as a healthcare provider, that's usually my go-to place. I talk with patients about healthy eating. It's important to be physically active. You should stop smoking. I provide individual-level recommendations to support health. But if we look at the impact of that on a population level, that has a really small impact. Think about it much like smoking cessation. A doctor talking with a patient in the office about smoking cessation is important and effective, but has a very small impact. The next rung in the pyramid is our clinical interventions. So that would be prescription of nicotine replacement therapy to help with smoking cessation, treatment for high blood pressure, high cholesterol, diabetes, clinical interventions that are effective in treating a symptom, but don't address the upstream factors driving it. Next, we have long-lasting protective interventions like immunization, cancer screening, and then finally changing the context. Tobacco tax, driver of smoking. Increasing tobacco tax has a larger impact than a doctor counseling patients in the office to stop smoking. But then finally, when we get to the place with the largest impact, here's where we see addressing the importance of addressing socioeconomic factors. So factors related to poverty, education, housing, and inequality. Addressing those factors has the largest impact, for many reasons, and in part because they're part and parcel what is driving many of these unhealthy behaviors and contextual factors. The other thing for us to be considering when we think about the importance of early intervention and maternal and child health is its really critical window of opportunity to set the course of health for kids over their life course. What's really critical in this Time magazine article, which is well known to most, I think, at this point, just helps us remember that early childhood, so prenatal period, early childhood, is critical in shaping future health in a way that we hadn't previously understood. We know that the health of a pregnancy, healthy birth weight, being born at term, is tied to later health and educational attainment, that prematurity and low birth weight are linked to health, including cardiovascular disease, diabetes, hypertension. And then in early childhood, we know from many studies known as the ACEs studies that adverse childhood experiences increase the risk of adult chronic disease. So this is a really critical time in people's lives to intervene and to focus our strategies. Even economists now have provided us with a nice way of thinking about the value of prevention program aimed at disadvantaged children here, as in this quote from James Heckman, but even earlier, the recognition that focusing on interventions that matter during the prenatal period is probably the most effective time to intervene. So the bottom line here then is that healthcare is necessary but not sufficient. Strategies to improve maternal and child health cross multiple domains and vary in their population level impact. And strategies impacting pregnancy can help improve health across a lifespan, so pay off for decades. So when I think about strategies to impact maternal and child health, I put them into three different buckets. I think about healthcare strategies, those that are provided in the course of clinical care, and I'll talk about where we are with those. I think about public services, sometimes in different agencies and sometimes working together. And then finally, economic strategies and some place-based initiatives. So where are we with healthcare strategies? Well, in the past decade, there's been a recognition that the health of a woman coming into pregnancy has an important impact on the outcome of that pregnancy. And so this concept of preconception care was introduced into the healthcare setting to help stimulate clinical care and coverage for clinical care for women prior to pregnancy. It focuses on optimizing health behaviors and health risks, initiating folic acid, which when given prior to conception reduces the incidence of neural tube defects, immunizations that can't be administered during pregnancy, but non-immunized women are at risk for anomalies if they do acquire the infection during pregnancy. Pregnancy planning, especially for women who are not ready for childbearing, for women with medical comorbidities that need to be improved before becoming pregnant, is really critical. The introduction of highly effective and reversible contraceptives have really revolutionized family planning. And the use of immediate postpartum contraception is new and growing as a very effective way to help patients meet their needs. Prenatal care has been out there for a long time, But there's a lot of innovation that's happening now in the delivery of care. There's a recognition that it's an opportunity to engage with the healthcare system and provide screening for medical, behavioral, social, and economic risk factors and help connect women to care, screening for depression, identifying women, and providing interventions to those in need. It's a time for improvements in risk factors. It's a great window of opportunity and a teachable moment for women to stop smoking, address substance use, and such. So the prenatal care, beyond just screening for hypertension and diabetes, has really emerged as a great opportunity to help improve health for women, which will then carry forward in the postpartum period and also impact the health of their baby. It's being delivered, again, in new models. There's now group prenatal care that's being used, some of which is based on the Centering Institute model. There are a number of states that are experimenting with obstetrical medical home models as a way to bring together broader multidisciplinary support to women during pregnancies. So prenatal care is really evolving to better meet the needs of mothers and their babies. We also have targeted interventions. I mentioned 17P, or progesterone supplementation, as well as the use of cerclage as a strategy to prevent recurrent preterm birth. It's a new healthcare strategy. Its uptake has been complicated and slow, but continues to emerge as an important strategy. And then finally, what's happening all across healthcare is quality improvement and improved systems of care. Much of what we do in healthcare is done better when there's systems to support that care. And quality improvement initiatives at the healthcare system level are used to drive evidence-based practice. An example is avoidance of non-medically indicated early-term delivery, as I discussed earlier. How do you get healthcare providers across the country to change their practice of elective delivery before 39 weeks? You do it using a quality improvement strategy. Another important area is the use of antenatal steroids. For women who do enter preterm labor, administration of steroids to mom facilitates lung development and lung maturation for the infant, improving greatly their survival. How do you make sure everybody who is eligible or would be thought to respond well to steroids, how do you make sure they get those steroids? Through quality improvement strategies. So this has been really transformational in medicine and will continue to grow over time. When I think about public health strategies, this has been, maternal and child health has been a key area for public health interventions for a long time. Health insurance is key. Health insurance enables access to family planning, preconception care, and prenatal care, not even to mention postpartum care and infant care. Nutritional supplementation, we can't forget how important WIC and food stamps have been in reducing low birth weight. Folic acid supplementation, which is often made available by public health, reducing neural tube defects. And then targeted behavioral interventions. Smoking cessation reduces low birth weight. Safe sleep campaigns have been launched in public health and decrease the risk of sudden unexplained infant death. And then finally, what's really grown recently are home visiting and care coordination programs. Healthy Start, early home visiting programs, screening and care coordination such as Durham Connects, prenatal care coordination. All of these public health or more community-focused programs have been working together to try to improve maternal and child health outcomes, both through connection to care as well as addressing other risk factors outside of clinical care. And this is just a reminder that we have federal and state public health investment and have for a long time through Title V, which is maternal and child health block grant program, through the National Healthy Start Initiative, which was recently transformed and is redesigned. Through the maternal, infant, and early childhood visiting programs, we have had a large expansion of early home visiting programs using evidence-based models. And as I mentioned, through the WIC program, which over the course of the past 10 to 20 years has changed tremendously and has increased support for breastfeeding for women on WIC. And then finally, there's increasing interest in the importance of coordination between healthcare and public health, where they intersect. Some examples here are the coordinated provision of preconception care, which crosses both family planning clinics that the state runs, for example, with healthcare settings. Another great example is in care coordination during the prenatal period and during the postpartum period. And then finally, an area that has been shown to have an important impact, especially in rural areas, is regionalized perinatal care, where hospitals, healthcare providers, and public health work to ensure that high-risk mothers and babies are born at hospitals that have the capacity to care for those complications. And then finally, quality improvement. Just as we saw in the healthcare setting, quality improvement at local, state, and regional levels, improving systems of care, have been transformational. And I'll show you a little bit of data about that. State perinatal quality collaboratives are the mechanisms that have brought together perinatal care providers and public health professionals that improve outcomes using evidence-based practices and processes, often toolkits that are implemented at the state level. California has been an extraordinary leader in this area, and they've had tremendous success at reducing complications related to hypertensive disorders, at pushing that decline in non-medically indicated deliveries before 39 weeks. And over time, and with support from CDC, there's been continued expansion in the number of states that have a perinatal quality collaborative. But finally, I do want to remind us that evidence is accumulating that support the use of some economic strategies. I'm going to put WIC and food stamps in this bucket as well. There is good evidence. There have been numerous studies to show that WIC and food stamps decrease preterm birth and low birth weight. But more recently, there's a recognition that economic strategies make a difference. A study by Hillary Hoynes, and there have been others, show that earned income tax credit reduces the incidence of low birth weight and increases mean birth. And she has an estimated $1,000 treatment on the treated leads to a 2 to 3% decline in low birth weight. That's extraordinary. Income support, a study in Canada showed that unconditional cash support reduced the risk of low birth weight and increased breastfeeding. There's evidence to show paid family leave improves birth outcomes. And then finally, we're beginning to see evidence that minimum wage matters, that economic strategies that affect women of childbearing age and families with young children improve birth outcomes. Briefly, I do want to mention that the strategies that I've been talking about have unevenly but slowly led to some improvements in infant mortality. And here we can see from the map the changes over a decade in infant mortality and how varied those changes are. There's more good news. We do see a decline in high rates of cesarean delivery, likely related to these quality improvement strategies that are happening in the healthcare system. Safe sleep campaigns appear to be effective. We see a decrease in SIDS related to the Back to Sleep and Safe Sleep campaigns that have been mounted in the U.S. And here we see very mixed findings. I showed you earlier the increasing rates of maternal mortality that we see across the country, but what I didn't show you is that we're seeing trends that are divergent by state. So the states that are not following the national trend are really important to highlight. California, a leader in perinatal quality collaboratives and in maternal health improvement, saw a decline in maternal mortality, which is really good news and suggests that these quality improvement strategies quickly lead to measurable improvements. On the other hand, Texas saw a sudden increase in maternal mortality, and the folks studying Texas are attributing that to the closure of maternal health clinics, of clinics in that state. We also are seeing an increase in the use of highly effective contraceptives in the U.S., and here we're not even seeing the most current data, but we see a rapid increase in the use of intrauterine devices and implants, which are safe and effective. Colorado mounted a statewide initiative disseminated through their Title X agencies, which were the local health department, which had an extraordinary effect on decreasing teen pregnancy and teen births, and had important outcomes not just on birth rates, but also on the percent of women having babies who are enrolled in WIC, kind of speaking to a shift in timing that will be very consequential in Colorado. So I do want to mention that there's critical research gaps that we all need to keep in mind. We need to continue to do a better job at identifying which strategies are effective, thinking about whether we're choosing interventions that have a large impact, looking to see if they reach the intended populations, and understanding if some groups benefit more than others. And finally, are the effects durable? When we introduce a new program and we see those positive outcomes, do we continue to see that over time? And for what groups? And finally, a reminder, again, that the strategies that we need to be considering to have an impact need to fall across all levels of this pyramid. And while we tend to focus on clinical interventions, it's really critical that we consider the socioeconomic context and the factors that are driving much of these outcomes. So main takeaway messages: infant and maternal morbidity and mortality rates, key indicators of the health of a community, are high in the U.S. compared to those of other developed countries. Racial disparities are persistent. Poor infant health impacts a child's health over their life course, so our failure to address this will continue to follow the health of our population as they get older. And effective interventions to improve birth outcomes include health care, but also include public health, social services, and economic investment. We need to have greater investment and strong evaluation in the strategies that we use in order to make a difference.